Wisconsin Eye is outside Wheaton Franciscan Healthcare St. Joseph's Hospital. Why are we here? This facility designed its emergency department to see 70,000 patients a year. It's now seeing 85,000. That's the most emergency department patients in the state of Wisconsin. We're here to talk with Wheaton officials and the hospital's medical director about the implications of lower MA reimbursement rates. They get reimbursed at 65 or 69% of their costs of caring for their emergency department patients, and what innovations they have had to adopt to help those patients. This is Wisconsin Eye outside Wheaton Hospital at St. Joe's campus. We're talking to Debra Standbridge, president of the Wheaton Franciscan St. Joseph campus. Debra, thank you and welcome.
Thank you very much.
Dr. Gary Swart, medical director of the emergency department. And tell us a little bit about what happens here at the emergency department, your soaring caseloads that we've been discussing about this, and changes you've had to make. So please.
I'll start by saying that we see over 85,000 visits at this site, which is just an incredible amount of emergency room visits for any one hospital. Our emergency department is actually built for 75,000 visits, and in recent years, the volume has soared to over 85,000 visits.
And as a result, Doctor, what changes has the hospital had to make to accommodate the increasing number of patients?
We perceive our emergency department, and in fact our whole hospital, as a continuous system. So any place that there is a block or a hold in that system decreases flow. So we start out the process on the front end. Behind us is the desk where we have a nurse that's staffed. We call her the nurse first, so that patients that walk into the emergency department are greeted by a nurse. That has several advantages. First of all, patients prefer to be discussing their medical care with a medical professional. And second of all, it allows for that immediate initial assessment to make a decision about what needs, what resources will be required for that patient, and to get that underway immediately.
Debra, this is the busiest emergency department in the state of Wisconsin.
Yes.
As a result, what unique issues does it pose for this facility, please?
And again, I think Dr. Swart has said that is, again, to keep the flow of our patients going through, to be able to see our patients in a very expedient fashion, to be able to make a rapid diagnosis, and then be able to determine for the patient and their family members how we're going to treat whatever symptoms they have presented for us, either through admitting them to the hospital or through discharging them to for outpatient care with a myriad of other types of consultant physicians or other types of treatment.
Doctor, what are the most common type of maladies that you see and treat in this department, sir?
One of the beauties of working in emergency medicine is I get to see and treat a broad variety. Patients present with complaints that might be as simple as cough, cold, fever, sore throat. They also present with very concerning problems such as chest pain, severe headache, extraordinarily high blood pressure. They also present with abdominal pain. They present with pregnancy-related issues, and then also with trauma, infections, just the broadest variety. And they all walk right up here, right up to this desk. Then we have to decide, how are we going to place them within our care in the emergency department? And we have a number of options. We use a pull-to-full process here, meaning as long as there's a bed available in the emergency department, a patient who presents with any complaint will go directly to a bed for the rest of their triage and care. Once we run out of beds, then we have to make a decision who needs to use the resource immediately, and who can we move to our minor care area where we try to expedite care for the simpler problems. And then the third thing that we do right here is make a decision if we don't have a resource bed in the back and the patient might not need it, and the patient is yet a little more complicated, we have protocols in place to initiate certain evaluations, whether that be an X-ray, a pregnancy test, certain blood work that we will draw right in our triage area, ask the patient to wait in the waiting room. But then when they do get back to a bed, we've already got some answers that we can work from.
Well, You're seeing 85,000 patients in this area. What are you concerned about in the future if this trend of increasing caseload continues? What are your concerns or worries, or what issues are posed by soaring caseloads?
Dr. Swart and I both know that a lot of the visits that we have here in our emergency department, probably over 60% of them could be best served by the patient seeking out a primary care physician and having them treated. When he was talking about colds, flus, those kinds of things, and patients are used to coming to the ED to be treated, that can really be handled by a primary care physician. At St. Joseph, we have put in over 7 physicians, primary care physicians on our campus. So if they come to our emergency department and it's something we can treat then, but in terms of follow-up care, we want you to see a primary care physician from this point on to handle those kinds of signs and symptoms and overall care, continuity of care with that person. That will help decrease some of the volume that we are experiencing here, better handled by an expert physician that deals with primary care.
Doctor, your projections, if you're seeing 85,000 now in 2014, 2015, 2016, even higher caseloads, sir?
As Debra mentioned, we hope that by being aggressive in care management, in helping patients manage the best place to get their care, that we can achieve hopefully a reduction in the emergency department volume. That being said, there will always be patients here, and we will always be here to see patients. But my projections would be that we will continue to look for novel solutions to manage those patients as best we can and try to keep the flow moving through the facility.
Dr. Swart mentioned something very, very important. We have a very dedicated team, a care management team made up of registered nurses and social workers, et cetera. We help patients link to a primary care physician or some type of medical home. We don't expect people just to go out and start dialing the phone trying to find one. We will assess where they live and where a primary care physician is in their community that they can easily access, as well as set up appointments for them to introduce them to that primary care physician.
Okay, so this is where 85,000 people come in and they all have varying conditions,
right,
and they will go next then to the emergency department?
Yes.
So maybe that should be our next place?
Why don't we go there?
So we just came from the entering where 85,000 people walk in. Now we're in the emergency department. Do I have that right?
Yes.
That's correct.
Let's talk about what happens here, please.
Certainly. The emergency department section that we're in right now, we refer to as the main. This is the area where the sickest individuals are brought for care, and the more complicated individuals. We'll see the minor care area later. This area consists of 25 beds, and those beds mostly have the capacity to do cardiac monitoring. Some of them are enclosed with glass doors. Others are open curtain rooms where we place patients that we need to observe possibly more carefully for behavioral issues. In this area, as you can see behind us, the central core is the area where both the nurses and the physicians and our health unit coordinators operate. Our systems are primarily computer operated, where we place orders, we document on patients. There are monitors that are stationed here where we can see the patient on a monitor, even from not standing directly at the bedside. The care here is all of the things that we talked about in the waiting room. We see patients here with chest pain, abdominal pain, severe headaches, all varieties of trauma, and we have a process of care where certain patients come in as alerts. So while we're standing here, we may hear a trauma alert or a stroke alert or a STEMI, which is an acronym for a heart attack alert. And you'll see providers start to move pretty quickly when those alerts come out.
We can't avoid healthcare finances. So here's my question. Changing in MA patients, Medicare patients, private care patients, what have you seen in terms of the demands, and who pays for that care, please?
When we look at our patient population here at St. Joseph, including the emergency department, we've seen our Medicaid population rise from last year at 50% to 55% this year. That's an incredible gain in the amount of Medicaid patients who are seeking care here at St. Joseph.
Which really intrigues me, because the statewide average, as you're aware, is 20%.
Right.
1 in 5 Wisconsin residents get their care from MA, and you're up to 55%?
We're up to 55% this year, fiscal year that begins in July.
Follow up, what additional financial strains does it pose on St. Joseph's then?
I think we all know that Medicaid here in Wisconsin only pays for 69% of the costs of doing that care, so there's a part of it that is not reimbursed. And as the population of our Medicaid patients rise, that's cost that is incurred to St. Joseph that we do not recover.
What really intrigues me, a follow-up here, is thanks to the Wisconsin Hospital Association, the Department of Health Services projected that I think 93% of those who were going to either have to seek health care through the federal ACA exchanges or find health care on their own would find that, but the Wisconsin average is only 54%. What does that mean for St. Joseph's Hospital?
We want to work very hard for those people who have not enrolled in an exchange program or in the Medicaid program proper. We help them here at St. Joseph. For example, if a patient comes in here to our emergency room and they're identified as not having any insurance, we have financial counselors here on site and social workers that will help that patient complete the application to become enrolled in either one of the market exchanges or one of the Medicaid products.
Dr. Swart, these numbers indicate that more than projected are no longer having health care in Wisconsin. So does that mean they're not seeing any primary care physician? They're showing up here, and is that old adage true that emergency care is the single most expensive care, sir?
I would say that emergency care is not cheap care, certainly. We do what we can in the way that we manage patients to bring the cost down as best we can. Patients show up in the emergency department for a variety of reasons. Frequently, unfortunately, it's because they don't have other access to care, being a primary care physician. The other reason sometimes that patients show up in the emergency department is because it may not be convenient for them in a situation where they don't have access to transportation or have child care issues to be able to access care at off hours, and so access care that is not appointment driven. And so frequently those are other reasons why patients may show up in the emergency department for their care rather than a primary care.
But if you could wave a wand, you'd rather they show up to be examined by a primary care physician before showing up at your doors here?
Let me tell you a story. This is a patient that's fairly common to this emergency department. It's the 30, 35, 40-year-old patient who may or may not have access to primary care, may or may not have previously had any insurance that would allow them access to primary care, but they have a chronic illness. And the chronic illness I'll use as an example is hypertension, but let's say it's hypertension, let's say it's asthma, let's say it's elevated blood sugar and early diabetes. Chronic conditions that are best managed by care that's provided by the same person over time to watch the progression of that disease and manage that progression. The patient may have their initial visit, and let's say it's a 35-year-old gentleman who has some chest discomfort and a severe headache, and they arrive in the emergency department and their blood pressure may be in excess of 200 over 100. That patient does need acute care. They need to, if that patient was in the doctor's office, they would be sent to the emergency department. So we do what we need to do to assess their risk, to control their symptoms, and to control their condition. Now, that patient is, from that point forward, is best served being cared for someplace other than the emergency department. We discharge the patient with a 30-day supply of their blood pressure medications. And recently, we have had developed a care management program that will get that patient plugged into a primary care doctor. But the patient may not be used to that model of care. And so perhaps they keep the appointment, but perhaps they don't. Or they have a transportation issue or a child care issue that keeps them from that appointment. 30 days from now, they run out of their blood pressure medication. 45 days from now, they're back in the emergency department with chest pain and a headache and a blood pressure of 200/100. That's the patient that is best served by a primary care physician to manage their chronic condition.
One more follow-up question before we go to another position here. Medicaid came up with a Medicaid Disproportionate Share Hospital, or DISH. Has that helped St. Joseph's pay for some of these soaring costs?
It has helped, but the DISH payment, as we know it in the state of Wisconsin, is what we call capped. It's capped at a certain level that no matter how many patients you serve, you're only going to get X amount of money. And the one thing that we are advocating is we're going to have to step aside. Yeah,
we're going to have to step aside for an ambulance.
Well, it's an urban hospital, we understand. So you were talking about the
DISH funding is capped at a certain level for hospitals, and that is capped no matter how many patients you see that are Medicaid patients. So, for example, what we received the past couple of years, if that fund had not been capped, St. Joseph could have received an additional $3 million to be able to service the patients and help us with the cost of providing that care.
So it's an issue of that being capped?
We would like the cap removed. And then again, something adjusted so that for the hospitals that serve the greatest number of Medicaid patients, we are receiving funds appropriate for that.
Dr. Swart, you were talking about Wisconsin's unique law dealing with emergency commitments or detentions. I may have the term wrong, but can you talk about how our law is unique and what burden it puts on St. Joseph's?
Absolutely. And in fact, just down the hall, I can see that there is an example of that sort of problem currently occurring. In the state of Wisconsin, the emergency detention or process that is in place to make sure that a patient who is at risk to themselves or at risk to others is cared for and evaluated, sometimes against their wishes, is unique in that emergency care providers in the medical aspect of care are not allowed to change or adjust that statute. Patient makes a suicidal statement. They are evaluated by a police officer to be at risk to themselves. They're placed under emergency detention, which is a 72-hour detention. But at that point, we are asked to medically clear the patient to make sure that they haven't ingested a substance or caused themselves injury that puts them at immediate life-threatening risk. And then, in order to reverse that emergency detention, or in order to get the behavioral health care that's required, there is a centralized behavioral health system to which that patient either has to go, or they will at times send mobile teams out to clear that patient and lift that emergency detention and get the patient the help that they need. The problem is that as funding for behavioral health services in the state of Wisconsin is shrinking, and particularly in this community, they have less capacity to do their part of the job. What happens is the patient is placed under emergency detention, they're brought for their medical evaluation first, and then, because behavioral health service isn't available, the patient is stuck here in our system. The situation going on just down the way here that I was referring to is that we have this patient who potentially is at risk to themselves. In order for that situation to be safe, we have to have that patient under direct observation by a provider at all times. So we now have to use our patient care assistants, nurses, aides, that sort of person, to actually sit outside of the room and watch that patient just to make sure that they don't have the opportunity to do something to themselves that we wouldn't like.
For how long, sir, would you have to dedicate a medical professional to watching that patient?
The amount of time varies depending upon the load in the behavioral health system. It is not uncommon for us to hold patients 8, 12, 16 hours, and I think the longest that I'm currently aware of was in excess of 2 days.
Now, you run a lot of Wheaton facilities. How many hospitals and how many?
Three hospitals.
Well, talk about the impact of this law on the Wheaton system.
Well, and think about it, because we earlier talked about this being the busiest emergency department. When a room is being held for 8, 12, 16, maybe even up to 2 days, that is one less room for us available to carry the amount of patients to be able to have that throughput available for the busiest emergency department in the state of Wisconsin. Every single emergency department deals with this issue, and it is a very serious issue in terms of ensuring that we have, when you come to an emergency department, it's an emergency and you want treatment. When your rooms are being held for this purpose, and sometimes it's not just one room, is it, Dr. Swart? It can be several. That reduces your capacity to serve.
What happens when this patient is released after 8, 10, or 12 hours? Are they just released to the community or some other facility, doctor, usually?
The process can occur one of two ways. The behavioral health services will send a mobile team to evaluate the patient on site at times if their risk is perceived to be low to moderate. That behavioral health team, that mobile team, will sometimes lift the detention here if they believe that the patient is safe and adequate follow-up resources can be established for the patient from this site. On the higher acuity, more severe, more concerning patients, those patients are ultimately transferred to behavioral health services at the Milwaukee County facility. And typically, because those patients are under a police hold emergency detention, the police department has to send personnel here to this facility to pick the patient up and transport them.
Because of this unique issue for Wisconsin, is Wheaton and other medical systems asking for some type of a change in our statute?
We have ongoing conversations about that, and it's best when it's that kind of conversation is held by a medical professional like Dr. Swart and his partners, to be able to talk from a physician's point of view of what they do to evaluate the patient and their competency in terms of their expertise and years of experience to assist in making sure there is a timely discharge of that patient to another facility or to an outpatient facility.
So it's a live issue with medical professionals and capital policymakers?
Exactly. Although we feel this here, because this is where we practice, this is a distinctly community-wide issue, and so it's being managed, that discussion is being managed from a community perspective.
Right.
Well, do we have one more stop on the tour?
Yes, we do.
Okay.
We've been discussing the continuum of care. So you both consider this unit an important part of that.
Absolutely.
Can you talk about where we are and what services provided here?
Well, now we're standing in an area of the emergency department that we refer to as minor care. And that doesn't mean that we treat it as a minor problem, but the patient's level of acuity and need for resources is more minor than in the major part of the department. This is decidedly an area where we focus on rapid turnover of patients in order to maintain that flow. This area accounts for roughly 35% of our overall patient volume on a daily basis. And it's open from about 9 o'clock in the morning till about 2 o'clock in the morning. And one of the unique features of this area is that it is staffed by advanced practice providers, physician assistants and nurse practitioners. And the reason that we do that is, first of all, they are highly effective in taking care of rapid turnover. And secondly, there is an advantage in terms of monitoring our cost because these patients are certainly supervised by a physician, but their care doesn't need to be directly hands-on provided by a physician, and that is an advantage to our operation.
And are you seeing this developing through the system?
Yes, we actually use the model that Dr. Swart is describing throughout all of our emergency departments in Milwaukee within Wheaton.
Is this a trend within the healthcare industry nationally?
Absolutely. Absolutely, for a physician to partner with an advanced practice health professional, whether it is a nurse practitioner or a physician assistant.
So what percentage of the 85,000 through the front door would be treated in this area?
This area is responsible for about 35% of the volume.
35%.
Mm-hmm.
Thanks for the tour. This is the final stop in the St. Joseph's Hospital. I really appreciate it. This is the observation unit. Tell us about that, Doctor.
Absolutely. This is, again, we refer to as our observation unit, and it's another unique facet of the emergency department that was created in response to trying to manage both volume and the finances of that volume. In this situation, it pertains to financing for patients who actually require being admitted to the hospital or staying in the hospital beyond their emergency department care. CMS has a rule.
Center for Medicaid Services.
Center for Medicaid Services has a rule that requires that a patient's condition needs to likely require at least 2 midnights in the hospital to qualify for what is referred to as an inpatient stay. In the age of DRGs, an inpatient stay is significantly better funded than what is otherwise referred to as an observation or outpatient stay. The idea is that if the patient's not sick enough to require 2 days or 2 midnights in the hospital, then they can probably have their problem taken care of, and we're not going to consider them as actually admitted. We're going to consider them as an outpatient in a bed. In response to that,
Which was put in place in October of 2013. So this is a recent rule.
Thank you.
A recent rule for hospitals.
Thanks for clarification.
in response to that issue, we are looking for ways to have those patients that don't qualify for an inpatient stay to stay as short a period of time in the hospital and reduce resource utilization, but still get them from point A to point B, just like if they were an inpatient. The patients that tend to fall into this category are patients who require evaluation for chest pain, who are not having a heart attack and who are not considered to be at very high risk, but require serial testing and a stress test before they can be discharged home. Another category of patient would be the asthmatic, who is getting better but who is not cleared, and they need further time to observe and make sure that their process turns around so that they're safe to be discharged home. What we found is that when we keep these patients as an extension of their ER stay, ER physicians and allied professionals have a unique ability to think in terms of minutes and hours as opposed to thinking in terms of days as an inpatient physician might. And so what we found, for instance, is that an average length of stay for a chest pain patient who still was an outpatient in a bed prior to opening this unit was in the neighborhood of 35 hours. We have reduced that length of stay by using this unit to an average of about 14 hours. And so, again, always looking to pare down resource utilization and move people through the system as quickly as possible to maintain flow.
And the reason that this unit is very successful is because of the targeted protocols that are in place for the patient populations that Dr. Swart is referring to. So when a patient is admitted here, there is a set protocol in place that the patient and their caregivers are engaged in immediately to begin to rule out certain diagnoses.
Okay, now let's do an overview. The governor will be recommending the 2015-2017 budget here in about 6-8 weeks. How important are these healthcare funding decisions in that budget to the Wheaton system and St. Joseph's?
They're very important, but we also recognize that Governor Walker and the legislature has a very difficult task going forward in terms of balancing the budget. So what we are asking Wheaton, as well as the Wisconsin Hospital Association, are some very targeted and focused asks of Governor Walker and the legislature. We are looking at first, number one, being the disproportionate share funding. Again, removing the cap from that funding so that we are able to have hospitals that serve the greatest number of Medicaid patients reimbursed fairly for that. So the cap is removed. The second one is what we talked about earlier as we were touring the emergency department, in that making sure that we have the ability to continue to fund all the care management resources we are now doing on our own to make sure our patients have the ability to access primary care. And again, as Dr. Swart said, at any one time, we know that there's a lot of patients who would be better served in terms of continuity of care by a primary care provider. But getting them to that access point takes a lot of resources. And those are the care managers, the registered nurses, the social workers, et cetera, that are helping to make sure that that transition from the emergency department to primary care happens. And then, as you heard Dr. Swart articulate so eloquently, is funding for behavioral health. That is an issue across the state of Wisconsin that you will hear a resounding, unified voice by hospitals in the need to take care of those patients and provide them the adequate care, the best care possible that they need to have with their illness.
Well, so the MA reimbursement rate for St. Joseph's, 65, 69%.
Right.
What are you seeking in the next state budget on that issue, please?
In terms of no matter how many Medicaid patients they see, we want the cap that is on DISH reimbursement removed and hospitals to be able to receive reimbursement appropriate with the patients that they serve in terms of Medicaid. The second that we ask, and again, very focused, is that in order for our patients to transition from the usual visits of the emergency department to a primary care, what has been in the budget in the past is incentive pays, additional pay from a primary care physician seeing a Medicaid patient, but being reimbursed at a Medicare rate. We want that to continue. That helps our physicians, again, be able to become whole, if you will, and to be able to have the appropriate reimbursement to serve the most urban areas in the state of Wisconsin, as well as the rural areas where the greatest number of Medicaid patients are at.
When I went to the Wheaton website to look at your annual statement, I was struck by this number. I'm just asking you to explain it. In 2014, $43 million in charity care. Can you talk about that? And
that's people that came to us without the ability to pay. Those are people that didn't have insurance, that people or were underfunded in terms of the type of insurance they have. We don't turn anyone away. We do not. No matter what their illness is, no matter what their background is, we accept all that walk through our doors. So if you come to us, no matter what your status is, uninsured or underinsured, we're going to take care of you. But it comes at a cost, and that's the number that you just quoted me, the charity care that we are providing to those patients most in need, most vulnerable.
Any PSs, Doctor?
Yes, I would refer to my professional organization, the American College of Emergency Physicians. Every 5 years, the American College of Emergency Physicians National does an analysis of every state and creates a report card for the perception of quality of emergency care and access to care in each state. Wisconsin consistently scores below average in that report card, and recently, in the most recent report card, actually slipped farther below average than they had been. Two of the major areas, there's 5 criteria, and 2 of the criteria that are causing the problem in the state of Wisconsin, as recognized by my professional organization, are access to care and Medicaid funding. Medicaid funding was quoted to be 65% of the 50th percentile in the nation in the state of Wisconsin. I want to be proud of my state. I want to be proud of the state I practice in.
Well, thank you very much. Thank you for giving us a chance to see all the facilities, talk about your innovations, and visit the busiest emergency department in the state of Wisconsin.
And thank you for your time today.
Thank you very much.
Thank you.
Thank you.